Our team recently took care of a 43-year-old man with a history of coronary artery disease, one stent in the past. The patient was presenting with shortness of breath and chest pain. Blood pressure was 95/50, and the heart rate was just around 100. The initial ECG showed T-wave inversions laterally and some depressions in the anterior leads that was suggestive of a posterior MI. The call went in from the field for a STEMI activation. The cath team met the patient on arrival to the ED and wanted to take the patient up for cath. But as we were reviewing that ECG a little bit further, we saw that the patient had a right axis deviation, which is extremely uncommon in patients with true STEMI. Given that ECG, PE rose to the top of our differential. We can often see ECG changes that look like a STEMI when the patient has a big PE. We decided to go to CT angio instead of to cath, and we found that the patient had a saddle pulmonary embolism. Given the low blood pressure, this patient was given systemic thrombolytics. There are two big take-home points from this case. Number one is to avoid premature closure. Don't jump to the simplest diagnosis. Keep your mind open to alternates. And number two is to remember that right axis deviation is extremely uncommon in patients with ST elevation MI and should prompt consideration for pulmonary embolism in patients with shortness of breath and chest pain. And remember that the ECG in a PE can mimic STEMI.